Welcome to ATCM, the Emergency Medicine Channel. Today we are going to discuss a case about a 59-year-old female known case of mood disorder who came to her ER with complaints of abnormal facial movements and history of altered behavior. Sir, on initial 10-second assessment, the patient was conscious and oriented on reaching the ER. Coming to the primary survey, airway was appearing patent with no pooling of secretions, and in the breathing part, air entry was bilaterally equal with respiratory rate of 21 per minute and saturation of 99% maintained in the room. In the circulation, her BP was 132/84 mmHg with pulse rate of 110 per minute. Disability wise, GCS was full score with pupil bilaterally equally reacting, and coming to the exposure, temperature was afebrile and GRBS was 138 milligram per deciliter. So further we went ahead with the history. In the history, the patient was a known case of hypertension, type 2 diabetes, osteoarthritis and mood disorder, and she was on sodium valproate and lithium for the past 6 years. So recently she was diagnosed with UTA and was...
What is drug automatism?
The patient
Sodium valproate she is taking.
Takes drugs multiple times before that.
And she forgets whether she has taken previously or not. They repeatedly take this drug. That one of the drug which can create this problem is drug automatism. Sodium valproate.
So recently she was diagnosed with UTA and she was on medication for the same, antibiotics for the same, and during that time her medications was and psychiatric medications was also stopped, and following which she was taking the medications.
What are the antibiotics you should avoid in patients who is having psychosis? Today morning fluoroquinolones should be avoided in this type of cases if possible, like seizure, psychosis. All fluoroquinolones can be avoided. Instead of that, you can go for some other drugs.
So after that, during her stay at the home, she developed abnormal involuntary movements of the face with facial twitching and lip smacking movements, and history of altered behavior was found by the bystanders. So there was no history of any fever, vomiting, slurring of speech or deviation of angle of mouth, and we went ahead with the routine investigations to rule out associated sepsis also. The CBC CRP was normal for the patient, and as the patient was on history of severe history of mood disorder with taking of lithium and valproate, we went ahead and sent serum lithium and valproate levels.
What are the side effects of valproate? Sodium valproate.
Valproate can cause drug automatism.
That is okay. That is a psychological problem. Other than that, sodium valproate patients who are having seizures, all patients take valproate. Peripheral neuropathy. What are the chronic adverse effects of valproate?
Renal,
hepatic. It's one of the most important hepatotoxic drug. Then peripheral neuropathy, anemia, gum enlargement. Okay, these all occurs in chronic cases. Okay, SIADH. Okay.
So we sent the serum lithium levels, which came out to be serum lithium level came out to 2.28 with the therapeutic range of 0.6 to 1.2.
What is this therapeutic range and how it is important in these two drugs? What is it? Sodium valproate and lithium.
So
what is this therapeutic range?
Therapeutic range is the normal range that a patient can have in the body. If the level is above the normal range, patient can go on to toxic levels. That is lithium toxicity. That is a level that patient has to be in the body for maintaining the mood.
If it is less, what is the problem? If it is more, what is the problem?
If it is less, the drug doesn't act.
If it is less, it will not act. If it is more, that will become toxic. These two drugs have got a narrow therapeutic index. That is very important. So it's very narrow. So at that optimum level we have to keep. slightly goes above, the adverse effects happen. Okay, especially lithium and valproate.
So as the patient had a history of UTA, most probably we were attributing the higher lithium levels due to the UTA induced chronic lithium toxicity. Infection induced.
Okay.
And for the same, there were multiple levels for lithium toxicity. If the patient is having a range of above 1.5 to 2.5, we just need to maintain IV fluids and all.
Okay.
But if the levels,
First of all, tell me, what are the adverse effects of lithium? What are the toxic features of lithium toxicity?
so in acute lithium toxicity, main features will be gastrointestinal symptoms like vomiting, diarrhea, and abdominal discomfort. Whereas in acute and chronic, the more severe
Abdominal pain is one of the most important problem of lithium. They can have diarrhea, vomiting, nausea. Okay.
and acute and chronic also, the symptoms will be same like the acute toxicity, but the symptom will be more pronounced.
Okay.
Whereas in chronic toxicity, the patient will have neurological symptoms. Patient can have agitation, lethargy, coma, and in severe cases, patient can have seizures also.
Seizures also. Yeah. Cardiac finding?
Cardiac finding, usually the patient is normally normal, but in cases patient can have dysarrhythmia and also ECG changes like QTC prolongation, bradycardia also.
Okay.
And in kidney,
Thyroid disorder?
Thyroid patient can have hyperparathyroidism and hypothyroidism. Kidney changes, patient can have there is polyuria and polydipsia can occur without and with
What is that condition called as?
arginine vasopressin.
What is that condition? Diabetes?
Diabetes.
Okay.
Insipidus.
Peripheral or renal diabetes.
Renal
insipidus.
diabetes.
Okay. So what electrolyte imbalance can be produced by
Hypernatremia.
hypernatremia?
The symptom is called arginine vasopressin resistant syndrome, and also patient also can have other symptoms like hypotension also. Hypotension, rigidity, and clonus, myoclonus also can occur. So that was the symptom, sir.
Okay. How do you manage this case?
So management.
So this is a chronic lithium poisoning, or sometimes I can call it as acute on chronic. Any infection can aggravate the problem. Okay, that might have occurred here. Okay, patient had rigidity.
Patient
CK was high.
CK was normal, sir.
Normal. Okay, that's rigidity and altered behavior.
Altered. No rigidity. Like lip
smacking and abnormal movements. Okay.
Altered behavior.
Okay.
So patients.
What is the lithium level in this?
2.2, sir.
Is it high?
It was high, but above the normal therapeutic range, but not above the level to be dialyzed,
Okay.
sir. So for dialysis, we have some certain levels for dialysis. If serum lithium levels are greater than 5, we should always dialyze. But whereas the patient is having severe symptoms, or if the serum lithium levels is 4 with the AK, we should dialyze the patient.
Okay.
That are the various points for that.
In acute toxicity, how do you manage acute lithium toxicity overdose? Suppose a patient who is having psychotic behavior had taken large dose of lithium tablets. How do you manage that situation in emergency room?
So patient should be
Patient is coming with a history of like 20-30 tablets of lithium. Who was on lithium for a long time. So that will become acute and chronic. How do you manage the condition?
So if the patient has taken a large amount of lithium within the initial 4 hours, we can give patient polyethylene glycol, which can help in remove the lithium.
What are the other options? One is PEG, polyethylene glycol. Other one?
That sodium polystyrene can also.
What is that? Is it available?
That is not recommended. This.
Is it available? That may not be a good choice. Is it available in our country? Huh? Yes or no? Sodium polystyrene sulfonate. Is it available? No. That is the same thing used in potassium or hyperkalemia. Sodium polystyrene sulfonate is caxylate. Okay, same thing. But it is not a recommended first choice. It is only last choice. So first choice is
polyethylene
glycol or activated charcoal. Okay, then.
Then
Stomach wash.
Stomach wash is not recommended.
If the patient comes less than 1 hour, you can try. After that, it may not be very helpful, but still larger doses, sustained release tablets, it may be helpful. Okay. Then after that,
After using the polyethylene glycol, we should maintain IV hydration for the patient,
okay.
and also
Where will you give IV hydration? In all conditions, you give IV hydration, or in selected cases, you give IV hydration?
if the patient has went into pulmonary edema or raised
Pulmonary edema, why should they develop?
AKI worsening as associated infections.
Okay, that is not the answer. When will you give fluids in a patient who is having lithium toxicity? Fluids are not first line choice.
Polyuria, polydipsia with
If the
hypernatremia.
patient develops severe dehydration due to increased urine output, like diabetes insipidus, then only you should start fluid. Otherwise, there is no point in giving fluids. But you can still give. Probably it may really removed through the kidneys. You can try it. But acutely, if the patient is having severe dehydration because of increased urine output, diabetes insipidus, then fluids are the choice. Okay, then.
Sir, after that we had to send for the serum lithium
Serum lithium levels are very important. Okay,
and
then.
we had to redo the serum lithium level every 4 to 6 hours to check for whether there is a reduction in the serum lithium levels or not.
Okay.
And if the serum lithium levels are not being reduced for the 36 hours, we have to dialyze the patient.
Okay, so the best treatment option is always dialysis. If the patient is having toxicity, acute toxicity, high levels, dialysis is the best treatment. Fluids can be given. That may, if the kidneys are good, it can remove the drug through the kidneys, but it is not that helpful. Okay, then.
The next thing we have to look forward is the rebound effect, sir.
What is rebound effect?
The serum lithium levels will, after dialysis, will again come above the normal range if because of intracellular lithiums being coming out.
Fat cells.
Fat cells.
Okay. So it can, like OP poisoning, in that condition, it can release from the fat. Here also, from the fat depot, it can release, and after sometimes again patient can develop lithium toxicity. So we have to be very careful. We have to monitor the patient. Okay.
So second HD might be needed in most of the cases.
What are the other conditions where dialysis is required in toxicology?
Toxicology, there are dialysable toxins, sir. One is lithium, then other will be methanol, ethylene.
Here, sodium valproate.
Sodium valproate.
That is one drug.
Phenobarbital, then salicylates and isoniacids, sir.
Okay, so all these things you require dialysis. Lithium is one of the most important drug toxicity where we use dialysis is a first line option, because if toxicity occurs, we have to treat fast. Arrhythmias, once a patient develops arrhythmia, then there is a chance of deterioration fast. What happened to this patient afterwards?
So this patient was managed conservatively with the serum lithium levels being in non-dialysable range.
Okay.
So patient's symptoms got reduced and later on discharged.
Okay. Any neuropathy was there? Peripheral neuropathy?
No peripheral neuropathy was found, sir. The other things we have to look forward is a long-term sequelae of the serum lithium that is silent. That syndrome of irreversible lithium effectuated neurotoxicity.
Okay.
That includes extrapyramidal symptoms with the midbrain and cerebellar symptoms. This patient was not having any of these features.
Okay.
And later on we discharged the patient.
So should we continue lithium or stop lithium? What was the plan by psychiatrist?
Stop the lithium and recheck the lithium levels after.
So there are better drugs available nowadays. We can switch to either one of that drug, or if we are continuing lithium, then we need to regularly monitor this type of patients. Otherwise, again they'll go to same situation. Rest all creatinine was normal. On discharge. Okay. Anything else you want to add?
In differential diagnosis, there are some differential diagnoses, sir, which include serotonin syndrome and neuromuscular.
What is this serotonin syndrome?
Serotonin syndrome is the condition where if the patient is taking serotonin SSRIs, patient can have symptoms similar to lithium toxicity, but whereas the patient will have hyperkinesia.
Hyper?
Reflex.
hyper-reflex
Okay, reflex are increased.
increase.
Tone is increased, reflex are increased.
Increase.
Then
Then increased
CK,
temperature.
creatine.
That
Creatine kinase will be increased.
increased.
Here it will not be
Not
increased. Okay.
then
Neuroleptic malignant syndrome.
NMS also it will be similar findings, but patient can have bradykinesia. That will be the differentiating factor.
Okay. Pupil. Difference
Normally,
between.
neurologic malignant syndrome, dilated immune syndrome.
Okay. So there are slight difference between neuroleptic malignant syndrome and what is that, serotonin syndrome, lithium
Lithium
toxicity. Here there is no high degree fever. In lithium toxicity, you don't get
High degree.
high degree fever, increased creatine kinase, but rigidity will be there. Okay. Anything else? Okay. Thank you.